Destigmatized Mental Health Podcast, Hope in the Valley series. I am here with Dr. Ashleigh Herera, and I am also here with Dr. Matthew Beare. Thank you guys for being here today.
No, thank you.
Thank you for having us.
Yeah, so it's our first episode, and today we're going to go ahead and be talking about what works in addiction medicine. Dr. Beare, you've been doing this for quite a bit of time. Is that fair to say?
Yeah, I mean, I guess that's all relative. I've been doing addiction treatment since 2019.
2019?
Yeah, so 6 years. That was a totally different time. That was like heroin was still the opioid of choice on the street. So the whole landscape has definitely changed a lot. But yeah, I've seen some ups and downs. I guess I've seen lots and lots of downs, but but yeah, no, I've been doing it for that long.
Gotcha. And Dr. Herrera, your research focuses on this specifically, correct? In regard towards addiction, being able to go ahead and engage in ways to go ahead and reduce some of the usage in regards towards opioid and stimulant disorders.
Yeah, so definitely a key area on our research agenda is how can we support people to be able to reduce risk and engage effectively with interventions to move towards our health goals. But also in my previous life, I was a clinician, I'm a licensed clinical social worker, and I was working in residential drug treatment along the same time that, Dr. Beare really shifted his focus to addiction medicine. I was doing addiction treatment, and we were on the ground when we started to see that change from heroin to fentanyl and what it's done in terms of the devastation to patient populations and communities and families, and then, working to figure out what's going to work for people in terms of efficacy, but also acceptability. So a lot of work ahead of us.
Yeah. But it's good work. It's really good work, right? Like I love it. I know it's so cliche, but I tell people all the time, like I genuinely never dread going to work any day of the week, just because it's such the rewards you see, the life changes you get to participate in and sort of be a part of. It's really so as much suffering, right, as we encounter every day, and the losses we see and the stigma we see and just the aches and pains of like living with substance use disorders that we see. The counter to that is that the triumphs are just insane.
It's incredible.
Yeah, it really is incredible. It's like profound, and I always, like, probably once a week I have this internal thought of just like how like surreal is it, how I don't know the right word I'm looking for, but how amazing is that people are willing to share like their suffering and their aches and pains and woes and loss with me, like who's typically a stranger to them when we first meet, so candidly, and like let me participate in this thing that's devastated their lives and the lives of their loved ones and their communities, and then have a role that is beneficial to them. Like it really is. It's righteous, I guess. I don't know. It's really amazing. So yeah.
Well, what I think is really special is that you've been so open to sharing that kind of practice model and philosophy with so many people. So, we met in 2020 after I moved to Kern County during the pandemic, and we were working together on the HRSA.
That's right.
Our core grant.
I
did.
Yeah.
And, that's when you had just started your street medicine work, and then you started inviting me to come out with you onto the river, which I, delayed the invitation, till we had, had our child, and the world was, less COVID-19. But it was really exciting to see it be flipped from this expectation that people come into clinic, people come into residential or outpatient settings to receive care. And your practice delivery model was so centered on bringing care to the people who need it the most. Understanding that as organizations, as clinicians, we have the capacity to offer something that they can't, in terms of how can we make healthcare fit people instead of people fit healthcare. And that was something that was so powerful to watch, because it was such a paradigm shift from the work that I had been doing previously.
Yeah, so that like street medicine model, which was introduced to me like right at the end of my residency, I thought the model was going to be like, hey, I'm going to take really high quality clinic care, the same kind of care we give within the four walls of a clinic, and I'm going to go take that to the streets. And then we went out to the streets, and I was like, oh, okay, this is totally different. That's not going to work. Like you have to absolutely meet people where they are, and it has to be like patient centered, patient guided, shared decision making. And so it was just like, okay, like I can't come in with my algorithms. I can't come in with my agenda, or even the medical community's agenda. I have to come in with like, hey, what needs do you have that I can help meet? And so then when I started doing street medicine for a while, I was like, this model like needs to be brought into clinic. And so I think it just sort of happened fortuitously, like the timing of me starting street medicine and starting addiction medicine worked out, where I learned very quickly that you cannot come in with some prefabricated idea of what you're going to do for the patient, but rather it's like, I'm going to sit here and listen and hear what it is you need and what part of that I can play a role in, and then do everything I can in my power to bring that. So that patient-centered autonomy that I learned in street medicine just paid off in dividends when I was doing like addiction treatment. So it's very fortuitous that I just kind of fell into all of that.
I'm curious to know, Dr. Herera, you mentioned that you joined Dr. Beare a little bit after COVID. We're recording this in 2025, going into 2026. So now that you have been able to go ahead and be part of that journey of being able to see how addiction medicine works in real time, I'm curious to know what your thoughts are and see how it's so different in comparison to how COVID was.
I think one of the biggest shifts that was happening on the treatment side was moving away from this idea of abstinence only recovery as the only path forward for people who want to stop using drugs and move forward with treating their addiction. And what we saw was that the tools that we had, these behavioral approaches, were not enough for how potent and deadly fentanyl was. And so we had to change the kinds of tools available and change what we thought recovery looked like so that we could meet the realities of the people who are looking to make meaningful change in their life. And so to me, that was looking like medication for opioid use disorder. And then understanding, what's the best way for people to start using these medications, continue to use them, and changing some of the expectations that this isn't just used for withdrawal management. This may be the tool that you need for the rest of your life to stay alive. And that idea is taking a lot of time to become normalized in the recovery community. And so there's a lot of resistance that's met in terms of people changing their perspective about how do other people's recovery look. And then you're seeing, I think, a lot of stigma and, this fear of rejection, or this idea that the only way to do recovery is abstinence, affect how people think about what options are available for them to make these kinds of changes that are so hard.
Yeah. There's a lot in what you're saying there. So I think absolutely, like the shift from purely 12-step groups, faith-based treatment of addiction into a more evidenced, which I'm not trying to say those are not evidence-based or have no evidence behind them, but into the more like medicinal treatment, right? Like medicine part of addiction is like, it was sort of a big sea change. Especially I think when the transition from methadone, adding in Suboxone or buprenorphine products. And there definitely was a ton and is still a ton of, I don't know if pushback's the right word, but hesitancy from the old school, sort of the old hat of recovery. And, I sort of have mixed feelings about that. On one hand, like, I encounter a lot of times like patients who are like, hey, I want to enroll in this program, but they won't let me be on medication. And it's like, that's so heartbreaking because your risk of dying is so much higher if you're not on, the risk of you losing your life is so much higher if you're not on these life-saving medications. And it's really for some ethos of like puritanical, like, no, you're not in recovery if you're still on medication, which is just, it's crazy, and it's a total misunderstanding of the disease of addiction. But then I also have to kind of keep in mind that these groups, the 12 steps, the AA, the traditional recovery centers, for the longest time, they were the only people who gave a shit about people suffering with addiction. So it's like I have this reverence where it's like, yeah, like you guys were the pioneers. This modality, this method was the only thing many, many thousands of people had to access for the longest time. So it really is, I have respect. And then at the same time, I hold that thought of like, but this ethos of no medication, you're doing harm. Like you're causing this is loss of life for a lot of people because, someone wants to hold on to an sort of antiquated idea. So I don't know. It's tough. It's really tough.
I think it's really tough. And I think it's people moving past their own experience because they were able to recover in one way.
Right. Yeah.
And today the drugs are very different. The experiences are very different. And more, I think people are also being crushed on social determinants, right? Yeah. So it's harder to have the facilitative conditions to get better, right? No one's going to recover on the street, realistically.
Yeah.
And so what can we do to support people in this new reality? And you and I have had some conversations too, where, again, like I started my practice in an abstinence-only treatment-based setting, and we were going in real time that shift, just, MOUD, and at the time it was Suboxone. But then when you're like, okay, I'm going to show you doing Sublocade injections, and because during this time, folks can be experiencing symptoms, you're like, I'm going to prescribe, like a mild amount of sedatives. And I freaked out.
Yeah. It freaks me out still. Don't, it freaks everyone out. That's okay to be freaked out.
But I had to do work for myself where it was, what's going on? Like, why is this coming up? And, shifting into this place that we trust people who have skills and expertise in what they're doing to understand that even if it's outside my scope or something I'm comfortable with, that doesn't mean that it's contraindicated for this person. Yeah. And having those conversations where you're like, well, it's not that much where something is going to happen. It's only for like a few days. It's better than if they did the alternative. So having those conversations with people in a way they can understand and take time to have that dialogue really helps you move past your own internal biases. And I felt that was really important when we were talking about, what was the best way for folks to make it through that time and be successful with their medication.
Yeah, I mean, I think what you hit on at the beginning there with like people who did recovery via abstinence only, that's sort of what they knew. And they know that to be successful. The reality is, though, that's very rare. Like very few people will reach remission of the chronic illness of substance use disorder via an abstinence only method. That is not the norm. So it's unfortunate that someone's like, hey, this worked for me. It has to work for everyone else. We see that all the time. Like, and the reality is like, it's a very complex illness, right? It is not, there is no one exact, there are really good approaches that are like very evidence-based. And it's like, look, if we utilize these approaches like medication assisted treatment, and adding on therapy and addressing underlying mental health and addressing all the social determinants, like then that's well established. Like you can look at the data to support that, but even that isn't going to be perfect for everyone. And I think people really, the general public would benefit from seeing addiction as a more nuanced, more complicated illness or disease process than what we currently do, because the way we're envisioning it now forms the way we treat it now. And if we envision it as moral failure, then we're going to treat it as moral failure. But if we envision it as a complicated neurobiological, relapsing, remitting illness, then we can not only come up with a more appropriate treatment plan, but we can muster up the same sort of empathy that we have for other complicated, deadly chronic illnesses. So yeah, I think that's the biggest, if we can just sort of collectively as a society rethink like what is addiction and what does it mean for someone to suffer with addiction, then we will have much, much better outcomes. And I think there are plenty of people in the field who started to catch on to that. So I'm optimistic.
I'm curious to know, Dr. Herrera, you mentioned that whenever you referred someone, whenever you would refer a client to see someone for addiction medicine, that there were feelings that would come up for you. As a therapist, of course, we talk about transference, countertransference. Why do you feel that came up for you? Was it because it was so early in your career, or because of the fact that you knew that being able to go ahead and engage in remedies for addiction medicine could actually save lives, or it could teeter-totter with the effects of their lives? What was going through your mind at the time?
I think it was just specifically related to sedatives and kind of the risk profile around sedatives. And if you co-use sedatives with opioids or alcohol, increases the likelihood that folks can overdose and die. And then, what's the potential in terms of vulnerability, given like the addictive properties of sedatives for folks, and just how vulnerable this patient population he's working with out on street medicine. We know they're struggling with, polysubstance use, multiple substance use disorders. And so it was my initial reaction, which is like from a abstinence only perspective. I was very on board with MOUD, and I had never in my, my time watching people do clinically managed withdrawal management for opioid use disorders, seen sedatives used as a comfort medication to support people. And so my own worries about sedatives were activated, but we had that conversation. And because I trust Dr. Beare as a doctor, from seeing his clinical practice, and then also he is a board certified specialist.
Double board.
Casey is
double board certified.
Double board certified. And then he talked me through it. I felt more comfortable with it, which I didn't need to. Like, I don't sign his order.
Right.
So, I don't oversee his practice, but I had never seen that before. And so that just came up, but it's been really important in my conceptualization of what gets in the way for people being successful to start MOUD. And then when we're having that conversation with people, centering that more, because that's their reality, right? They're getting really sick, and what they're worried about every day is staying well. And that's how they're orienting their life. So if we're talking about how do we take a next step onto a medication that's going to help you, well, in the interim, how much is it going to hurt me? And then if we can talk about ways that there are doctors that are really focused on that understand those symptoms and want to support them to move through those in a less painful way, then that really centers their experience and needs. So I think him taking that time to go over different routes for comfort medications has actually been really helpful moving forward in our work, where we're doing, street outreach and working with people through this process of change, especially when they're like in pre-contemplation, contemplation, preparation, more information in a way that is presented to people in a way that they can understand and addresses the issues that really matter to them has been important in these conversations as we're supporting them to move along that continuum of change and get ready to work with an addiction medicine specialist.
Dr. Beare, you talk about the old school as well as the new school strategies to go ahead and treat opioid and stimulant use disorders. I'm curious to know what have been the most effective strategies that you've been able to see when it comes down to opioid and stimulant use disorders.
So in terms of treatment, I think the most effective, so there's a lot to break down there actually. So for let's talk specifically about opioid use disorder. For opioid use disorder, we have a series of medications that are life-saving medications. There's methadone, and then there's buprenorphine products. There's also a third class of medications called naltrexone or Vivitrol. These medications are very well demonstrated to reduce your risk of overdose and death. I mean, dramatically. Like when we think of effective medications, there's a sort of principle in pharmacology of like what's the number needed to treat, and it's a mathematical calculation that you make to see like how many people need to take this medicine for you to get the desired therapeutic outcome. So a medication like a torvastatin, which is a cholesterol medication, is gold standard. Like if you have the risk factors, then you are placed on these medications, a statin medication. The number needed to treat for a statin is something like 70 to 100. So 70 to 100 people who you prescribe are you need to treat 70 to 100 people for one person to not have a heart attack or stroke based on that intervention. And that's considered like, that's a very effective medication. Suboxone is 2 to 3. The number needed to treat is 2 to 3 to prevent a death, an opioid overdose and death. So that's a profoundly impactful medication. So wait, now I lost my, what were we
You're doing great.
No, I just lost where was I into this? Like,
That it's very effective?
no, I know, but what was the question?
No, we were asking what the most effective strategy
Yeah,
is.
so that's the most effective in terms of if you're just like, look, I just want to prevent this person from dying. That is a well demonstrated way to do that for someone who's struggling with opioids. I think if you're talking about like, okay, well now we've prevented someone from dying, but we want to keep them in long-term recovery, or we want to help them meet whatever goals their recovery goals are, then these medications are phenomenal at controlling long-term cravings for opioids. I think there's a lot of pushback when you start talking about, hey, I'm putting you on a medication. The reality is like this benefit of this medication is likely to be last for decades and years. So you would likely benefit from being on this medication for years to decades, right? A lot of people come in with this idea of like, oh, I only want to be on this for, 6 months or some predetermined amount of time. And I get that. Like, I totally understand not wanting to be on medication every single day for the rest of your life, especially a medication that has as much baggage as these medications do. But the reality is, if we were talking about any other chronic illness, right? If you came in and you had out of control blood pressure or diabetes or thyroid disease or crazy cholesterol, we would be talking about putting you on a medication likely for the rest of your life, right? And there's very few people who have massive qualms with being on cholesterol medication the rest of their life, but there is definitely 100% of my patients who are on buprenorphine. There's this push to get off as quickly as possible. A lot of that push, I think, is internal. A lot of that push is like, look, I don't like being physically dependent on a medication, and I totally appreciate that. I think that's a reasonable concern to have. But I think a lot of the push is also externally. I think a lot of people in the recovery community still hold this idea that like, if you're on a medication, then you're not quote unquote clean. You're not in full remission of that illness. And it's really, really devastating because we've seen countless people. I cannot keep track of the number of patients we've seen who did really, really well, got on the medication, were doing well for months and months, a year plus, and they're like, hey, I want to get off the medication. They taper down, get off the medication. We lose contact with them only to find out later that they overdosed and died. Or we lose contact with them for a year and then they come back and be like, yeah, as soon as I got off the medication, like I kind of found myself back in the same spot. And it's really, really tragic because I feel like if that external pressure to like, hey, you need to get off these meds, if that was gone, then we'd probably have a lot less of that, lack of recovery or that slipping away from the stability they had.
I mean, it sounds like there's a portion of it that has a negative connotation because of the taboo. A lot of the clients that I deal with that talk about taking any sort of medication assisted treatment, they usually talk about how, well, I'm going to go ahead and start a new addiction to go ahead and get off of my addiction.
Thank you for saying that. So that is like, I get that all the time. Well, now I'm just addicted to this. I'm trading one addiction for another. And what that demonstrates is a gross misunderstanding of the disease process of addiction. So addiction is not just like, hey, when I don't take this, I get sick, right? Withdrawal and dependency, those are parts of the diagnosis of addiction, but addiction is a disease that is a sequela of symptoms. And it that's a dog's tail is so good. That is the disease includes problems with personal relationships, legal issues, inability to stop despite like the desire to stop, higher and higher doses needs. So it's an entire picture, right? When we think of addiction, it's not like, oh, we're just thinking of one thing. It is an entire life wrecker. Physical dependency is a chemical property. It's how a chemical interacts with your chemistry, right? So diabetics are physically dependent on their insulin. Nobody would make an argument that a diabetic is addicted to insulin, right? It's absurd to even to make that. But because this is addiction, like people are very comfortable saying like, oh, well, now you're just addicted to that. No, there is physical dependency, and the physical dependency is problematic, and it sucks from just a day-to-day basis. It sucks to have to take medication every day, and if you don't take that medication, you're gonna get sick, and it sucks to have to go to the pharmacy, and it sucks to get the stairs and all that shit that comes with it. But Jesus Christ, it is so much better than that disease process of addiction being rampant, right? And again, if this wasn't addiction we were talking about, if it's like, yo, you are physically dependent on your SSRIs, yeah, that's just, there's nothing you can do about that. That's how these chemicals work with your body. And there's special precautions you want to take and ways you want to adjust so that you can mitigate those symptoms, mitigate those factors. But it is not the same as addiction. I really, really think people need to drive home that thought that physical dependency does not equal addiction.
What does the evidence say when it comes down to that, Dr. Herrera? Some of the research that you've done when it talks about some of the negative connotations or the taboos that come associated with getting started with medications for opioid use disorders or stimulant use disorders.
So I think Dr. Beare provided a great overview that really folks do perceive this to be trading one addiction for another. This idea that I don't want to have to take a medication for the rest of my life, that this is not really doing recovery. And I think, it's having these conversations and reframing things for people and helping them to understand it as a chronic disease. And when we don't treat chronic diseases, they end in death, right? So I get this is not the way that you would have had a vision for how you want your life to be happening. And this is the best tool that we have available to support you in modern medicine. And without it, the trajectory for this is to die.
Or live with decades of just a level of suffering that I think anyone who's never struggled with addiction can understand. Like the day-to-day suffering that comes with, watching people you love die and seeing people you love just have almost a deep hatred, like seeing the disappointment in the eyes of your loved ones and the medical community, and just living with that shame and guilt and physical
health problems that result, and then the social exclusion,
exactly,
stigma, shame, and then as there's more and more psychosocial impairment, invariably there's more and more trauma, and then it's harder and harder to treat because now we have all these co-occurring disorders, comorbid, trimorbid things happening to you physically, psychologically, and then also in terms of addiction, and it becomes harder and harder to make a change because there's so many things affecting that disease course progression.
And you can't effectively get treated for anything else going on in your life, right? Because there's so much stigma within the medical community that anytime you go, say, to the hospital because you have an abscess or something, you're gonna be treated a certain way because people are going to see you as less than. And so, not only is the addiction itself going rampant, but all these underlying things, you're not getting any of your healthcare screening. You're not getting your mental health, right? Like one of the biggest contributors to substance use, you're not getting that touched at all because people are going to think like, oh, you're drug seeking, or they just treat you a certain way. So it is a degree of suffering that is profound. Of all the, illnesses, all the disease processes I've treated over my course as a physician, addiction is one of the most, if not the most suffering involved disease process. It's so heavy. And I don't think the lay person can fully appreciate that. So yeah, it's just tragic. It's absolutely tragic.
Well, I think what we saw in our research with your unhoused patients was that the folks who needed the most help had gotten so disengaged from the healthcare system because of all these negative experiences and these expectations of the patients that they're abstinent, adherent, compliant, and if they can't do those things, then they don't deserve medical care or they can't effectively engage with behavioral health care. And it was this stair-step approach where it's like they can't even hit the first stair. So they can never get the things that they need. And then they feel hopeless and disempowered and they just give up and think it's never going to get any better for me.
I mean, imagine for a second that we treated any other disease that way. Imagine that we withheld treatment from diabetics if their sugar wasn't perfect on a day-to-day basis. Like, but that's essentially what we're doing. Like, we're excluding these people from care if our arbitrary specific goals aren't being met. So it's absolutely devastating. And I think part of the way to move forward and us as a society be better about helping those with addiction is to reframe how we see addiction. Stop viewing it as just moral failure and like, oh, this guy or girl is just, they're innately bad and they do bad things and they make bad choices, and understand like, no, there's so many contributing factors to one person struggling with addiction and someone else not struggling with addiction. And I know like we all like to think that, or we're all taught rather, that addiction is because of your choices. And that's just not the full picture. Like I tell, or I speak with my patients about like, I vision addiction as sort of like this equation, right? You get X plus Y plus Z equals addiction. And I'm absolutely comfortable leaving choices as part of that equation because I think choices are a part of every disease process, right? Like the food you eat is going to be a part of diabetes and cholesterol and all that sort of stuff. But choices is just one small piece of this equation. And the other pieces that we all just sort of turn a blind eye to are genetics. Genetics have a huge contributing factor to the disease of addiction, as does mental health and socioeconomic status and trauma and ACEs. And like, there's all these things. There's so many factors that lead to this disease of addiction. And all we really want to focus on is the choices. And that's just not doing right by the disease process. So I think, again, if you can sort of see the more nuanced, complicated contributing factors of addiction, then I think it's easier to have a really solid treatment program to address all of those factors, but B, and maybe more importantly, for us as a society to muster up the empathy to see this as a really horrible, suffering state for these people. It's not just like people with addiction are a drain on society and the crime that's associated. Yeah, but think of the suffering. Really think of the human suffering that is happening day to day in these people. It is so massive. And if we can't envision it appropriately, then we're just going to see like, yeah, we don't have to think of it as suffering because it's like, no, these are their choices. Like, this is what they want. So yeah, it's horrible.
I agree. I mean, I think that we have to do this realignment now culturally in terms of how we view addiction, because we've developed really great medications that work. And if we can increase awareness of these medications, and now that there's more options about how to onboard on the medications so that people aren't getting as sick, then there'll be more reach. But the other piece is the social piece. And so if there isn't more buy-in, right, in their social networks, which is leading also to internalized stigma and shame, it's going to be difficult for people to be adherent long-term and get the outcomes that they want for their health. On the flip side, with stimulant use disorder, we haven't had as much progress in terms of developing effective medications. And I know I've been out with you a few times when you've tried different things with people. Could you talk a little bit about some of the medication-based approaches that have been tried with your patient population and some results?
Yeah, so the stimulant use disorder is a whole other beast. It meets a lot of the same. It still fits under the umbrella of like suffering and shame, and it probably has a bigger immediate health impact compared to opioids, right? Like opioids are going to kill you if you overdose, but the long-term effects of opioids aren't as profound as the long-term effects of methamphetamines, which are just absolutely devastating. And so it is really tragic that we don't have the methadone or the buprenorphine for people who are struggling with stimulants. That doesn't mean there's nothing. It's kind of wild, actually, that the best intervention for someone who's struggling with a stimulant use disorder is completely non-medical. It is something called contingency management, where basically someone enrolls in a program, they show up a couple times a week, they give urine. If that urine is favorable and shows no stimulants, then they receive a gift card. And then the next time they come in, their urine is favorable, it's a little bit higher amount of gift card. And it keeps going up and up and up over typically like 12 weeks. The wild thing is that intervention is really, really impactful and really, really successful. And the weird thing is they've studied it in other substance uses. So they studied it in opioids and alcohol, and it just doesn't have an impact. It really is specifically has an impact for people with stimulant use disorder. Now, there are a lot of problems like with it as a whole, because it's hard to get people into these programs. There's not a ton of contingency mode programs available in Kern County. There are more today than there were, when we first started doing this, but there's still the logistical, like how does someone, especially someone who's like maybe experiencing homelessness or housing instability or severe mental health, like how do they show up to these appointments week in and week out? So it still like has a lot of issues making that happen, which is why we're happy that there are some medications that have shown some benefit. There's naltrexone, which is a medication that we typically use for alcohol and sometimes for opioids. There's a naltrexone bupropion combination that has some pretty promising results. It's not profound the same way that methadone and buprenorphine are for opioid uses, but it's something, right? It's a tool that is evidence-based and can provide some benefit and reduced amount of days and exposures to methamphetamines. There's topiramate, there's mirtazapine. So there's sort of a myriad of other off-label medications for which we can use off-label to treat stimulant use disorder that can help to a degree. One of those being, a lot of patients that we see with stimulant use disorder are actually self-medicating for untreated or undertreated ADHD, ADD. And so that's kind of a nice one, because when you have those patients come in and you're like, oh yeah, you are very obviously like struggling with ADHD or ADD, and it's been untreated since you were like 16. The nice thing is when you start treatment for those patients with like the classic ADHD treatment, they do really, really well, because they take the prescribed medication like, oh yeah, that need to use meth is just gone because now I feel normal. So that's been a really profound one. And there are guidelines through our governing organizations like ASAM that talk about like you can actually, even if someone doesn't have ADD or ADHD, you can use in the right setting with a specialist, you can use these medications like the Ritalins, the Vyvanse, the Concerta. You can use those to treat someone with a stimulant use disorder as sort of a way for them to use less of the harmful, right? So right now, the entire drug market is basically tainted with fentanyl, whether it's benzos or methamphetamines. Everything pretty much has some degree of fentanyl in there. And so if we can reduce our patients' exposure, to methamphetamines, like anytime they use their Ritalin or their Vyvanse, that means they might not use the methamphetamines. Great, we're keeping them away from all the harm that comes from the methamphetamine, but also we're potentially saving them from an overdose of fentanyl, which happens all the time right now. People are taking their methamphetamines and dying of overdose. They don't even want to use opioids, but because it's contaminating the product, they have it. So yeah, there's a myriad of medications. The most evidence-based right now is still a behavioral intervention. It's just we need more access to it, I think. Yeah.
I think I find that to be interesting, Dr. Beare, the notion, the gift card. As an incentive to go ahead and continue their stimulant use treatment. When that first came out, I was like, there's no way this is going to work.
Even when I read it, I was like, no, I'm reading something wrong. This is hokey pokey. Like, this does not sound like it can be actual. But then I read the actual studies, like, wow, this is very good data. Like, this is
right.
And, it's like one of these things where in the data, it's really effective. in practice, and I don't know if it's just because we haven't had saturation of enough patients on contingency management to actually see like that massive benefit that's been seen in the literature, but in practice I haven't seen a huge sea change for people who are in contingency management. And I don't know if it's, again, we just don't have enough saturation in the community of it, or what is going on, but I'm still hopeful because the data is very clear on it. I think we just need to do better by what we're doing locally.
Yeah. One of the things that we were talking about earlier in the episode were communities of color, and which is a population, in Kern County specifically, where we're at, is something that you deal with on a daily basis. What do you feel that some of the barriers for communities of color are facing in accessing treatment, whether it's insurance or cultural stigma, mistrust in the actual health system itself? Talk to me about that.
I mean, I think like all the things that affect people of color within our community, access to healthcare, stigma, I think it just sort of reigns over addiction treatment as well. So I can't think of much that's specific for people of color receiving treatment for their addiction that is unique to their addiction, if that makes sense. It's like, yeah, those things that, like, all the prejudices and all the things that keep people of color from receiving appropriate health care as a whole apply to addiction as well, but I don't think they're unique to addiction. Mm-hmm. I'm interested in what you think about that, Dr. Herera.
I think certain communities are more likely to be surveilled than others. And so then if we are acknowledging as a community that we have a problem, then we're calling more attention to ourselves. So then there can be this pattern of, trying to manage problems internally without letting people know, or it becomes more normalized because folks in that community are having to try to hold these problems and protect these people from outside entities like law enforcement, which unfortunately really intersects a lot with addiction, whether it should or not.
Very good point. Yeah.
And so then, is that effective? And then if we say there's a problem, right, how is that going to play into ideas, stereotypes that already exist in the broader society about us as a cultural or racial group? And then this idea, like, we have to try to be model citizens, or we're going to be further discriminated against, doubly discriminated, because the disease of addiction is so stigmatized already and criminalized. Yeah. So that's part of the conversations we're starting to have, where we're hearing people say, well, this isn't a problem for us. And then I think even more specifically, certain communities haven't historically been using opioids. Yeah. So then they don't see the risk for overdoses pertaining to themselves or the people they care about, because these conversations about the contaminated stimulants or the counterfeit pills aren't happening in their communities, kind of because of this idea, like, we're not really going to talk about it, because if we talk about it, then it's a problem, and then people are going to come and start.
Right. It's a very good point. I think it's also fair to acknowledge that, like, this is very likely a massive blind spot. Both Dr. Herera and I are white, educated, right? Like, so there are parts of this that we just will have no real insight into, because that's not the life we've ever had to live. I think there's something to be said that even us as outsiders to the marginalized communities, if we can appreciate, like, oh yeah, there is a lot going on that is harming these communities. If we can see it from very far outside, then there's probably a lot that we cannot see, right? I mean, tons and tons. So I think that's probably a better conversation to have with someone who's, like, living that day to day.
Yeah.
I think something that struck me, Dr. Beare, was when we started our outreach in Delano, it was such a shift from what we've been doing in Bakersfield, because here in Bakersfield, because it is our largest metro area here in Kern County, there's a lot more service providers, there's a lot more outreach, there's a lot more engagement. I think almost everyone we talk to knows what's naloxone, the generic for Narcan, and has some sense of how to use this, what this might look like. But then when we got to Delano and we were asking people, did they want naloxone? Had they heard about naloxone? They had never heard about it. They'd never seen it. And
That's wild.
fortunately, we had team members, who are bilingual and could have these conversations with them in Spanish. But then the box is in English, right? So then we're in this process of developing specialized instructions, translated into Spanish so that people could see what are the signs of overdose and then how to successfully reverse an overdose, because the box alone isn't a good intervention like it might be for other populations because it's not in English.
Yeah, that's wild. I hadn't even considered that.
And Delano's a very interesting just population within itself, because it's not only Spanish speaking, but we also have our Philippine Tagalog community there. So being able to have those conversations, not just with the whether it's the Mexican, Salvadorian, Guatemalan population that is big in Delano, but then we also have our Philippine Tagalog population as well. So I'm sure that was a challenge within itself, Dr. Herrera. Is that safe to say?
I think that's a space we want to grow into, and that is part of what we anticipate in our upcoming work as we continue to translate materials into the languages that are relevant in our community here in Kern County. But when we think about the diversity we have here, there's so many different linguistic groups. And are we really having these conversations, with trusted cultural messengers across groups to be able to engage people and break down stigma and talk about what are the risks and what can we do for prevention? And also, if we're in a situation where someone is struggling, what's available for treatment? And then really debunking those myths and allowing people to see the evidence for what's working to save lives.
Yeah, and I think that's a good reason why you want the teams that are approaching these populations to also be diverse, right? We don't need just a gaggle of white educated folks out there. Like it should represent the community at large. I think it's also, we're thinking about, we were talking about like the Filipino community, and it's I just sort of had this epiphany that it's wild that there's a relatively large Filipino community in Kern County, and I don't see a ton of those patients in clinic, which there's something there, right? Mm-hmm. Like addiction doesn't spare any racial background. So there's absolutely something there as to the breakdown in receiving care. So.
And I feel like that's where my passion comes in, in regards towards being able to understand the cultural dynamics of treatment when it comes down to destigmatizing. The reason why I do this podcast, right, is because of that very reason, to be able to discuss the cultural barriers. In the Hispanic culture, there's familialism. There are proverbs that exist that prevent individuals from getting specialized treatment. And I believe that is also to be true in the Philippine communities as well. And again, as we engage in these series, we do hope to go ahead and tap into specialists or even members of the community that would want to go ahead and talk about how this has affected their communities, their families.
Yeah. I think those are like very important conversations to be had. Yeah. One sort of odd phenomenon that I saw, and it gave me a lot of hope. So I've been adjacent to the Latino community my entire life. I was born and raised in Texas, lived in El Paso. Like I had, extended family members that were, from Mexico, and like the Mexican culture has always been a part of my life. And I've kind of knew of this, like we don't talk about mental health sort of thing. I knew that was sort of ingrained in me. And then, a few years back when the drug market was switching over to fentanyl, we saw this massive uptick. You guys probably remember like this massive uptick of kids in high schools getting into fentanyl, right? Yeah. And what I saw was a ton of those. Like my up to that point, the majority of my patient population was Caucasian, with some non-white people here and there, but massively Caucasian. And then when there was this big uptick in high school students and junior high students using fentanyl, I saw for the first time a bunch of adolescent patients, and a lot of those were Hispanic. And that's absolutely tragic. And again, that speaks to like there's something going on there that this would affect Hispanic adolescents more than Caucasian adolescents. But what was really sort of uplifting or made me sort of turn an optimistic eye to this was that 100% of these Latino adolescents had their parents involved in their care. So they were like the next generation that was sort of getting rid of that idea of like, we don't talk about this, we don't talk about mental health. And they were having very candid conversations about their anxiety, their depression, their substance use in the room and they don't have to, like, you don't have to bring, if you're coming to a doctor's office for a substance use disorder, you do not have to involve your parents whatsoever, but they were electing to, and the parents were very involved. And so it was really reassuring to see like, oh yeah, no, like this next generation, like they're kind of breaking these ideas of like, no, these are things we don't talk about. So in tragedy, at least there was that little bit of optimism.
I think what's cool, and this is from many years ago now, like 13 years ago, we put out this paper, but it was about older Mexican-American heroin users. And what we found, because before, Latinos weren't dying from overdose during the heroin phase of the opioid epidemic in the same way that white people were. And what's going on here? So like in our qualitative study, what we found was that there was more familial support for people who were using opioids, and that their families were engaged in all these strategies to try to keep them alive and care for them. And that was something that culturally was different. Mm-hmm. And I think that the tension is that there's all this language that goes on around addiction about family members and how should they engage with somebody struggling with addiction, where it's like, you shouldn't enable them. You shouldn't do these things for them. It's actually, you're keeping people alive by feeding them, providing them with a safe space to be, so they're not out on the streets. So this discussion around enabling needs to change, because people can't get better and people can't stay alive, without social support, without access to basic needs. And how can we better equip and support families to do the things that they want to do, which is love their loved ones and help them stay alive? So I think there's something really special about what was happening there. But like you're highlighting, there's this huge shift to fentanyl. And then also this risk now, where before folks might have been using methamphetamine, but now it's contaminated with opioids. And that risk seems to be increasing in terms of the awareness of the folks we work with. But broadly, is that understood? I don't think so. And so now we're seeing this steep acceleration of deaths in Black, Native, and Hispanic communities that just did not happen before. And so now it's, how do we reach other communities better with messaging so they understand the risk, and then also what's available in terms of supports, and what does support really look like?
Yeah. Again, I think a lot of it comes, I think the message of this is a severe chronic disease that is complicated and nuanced, I think that can permeate all, because every cultural collective knows how to be empathetic towards those who are suffering. And so I think if that can be sort of the loudest message, then I think you can have headway there. But that's my take on it.
Yeah. So here I have a little naloxone kit that was given by Hope in the Valley. You could follow Hope in the Valley on Instagram, Hope in the Valley CA, or you could go ahead and give them a call at 661-412-4014. And this little kit is really cool. There's 2 little naloxone sprays, Narcan sprays, 4 milligrams. We have a CPR face shield, and we have some handy dandy just tools as to how to administer Narcan. Signs of opioid use. There's the acronym BLUE: breathe, lips, unresponsive, eyes. And then there are other symptoms. And the reason why I'm even showing this and even talking about this, and then there's a little hourglass, and I'm definitely curious to go ahead and have a better understanding, as well as those that are listening to this podcast. A lot of my followers, a lot of the people that are, watching or listening to this episode, they usually go to raves, or they will usually go to places where there are going to be opioids and stimulants. I'm curious to know, one, Dr. Herera, where did this idea to go ahead and create this kit come from? And 2, I'm curious to know about this hourglass. And 3, being able to go ahead and have a better understanding of how we could even address those individuals that do go to raves, that do go to Stagecoach, or they'll go to Coachella, they'll go, and so that may be exposed to opioids and stimulants, and why it would be beneficial for them to have one of these kits by getting in contact with Hope in the Valley. So we'll start with you, Dr. Herera. Where did this idea come from?
So 2 years ago, we were at ASAM in Grapevine, Texas, and I was connecting with some colleagues, and one of them is Dr. Hansel Tooks from the University of Miami. And one of the conversations that we were centering on during our time together was about people overusing naloxone. And so what that looks like is that they're in a panic and they're not holding time well between the dosing. And the way this medication is designed is that you need to wait a full 2 to 5 minutes between administering doses, because someone may not need the second dose. And if we onboard too much medication too quickly, we could put someone into precipitated withdrawal. And then we're setting them up for a whole other host of risk factors, right, that could affect their health. And so he was sharing a story about, they're in the hospital, they're doing some training drills, and then they're administering naloxone. And even the doctors wanted to, administer very quickly. And the nurse is saying, "Doctor, it's only been 30 seconds. Wait." And, several times the nurses had to remind the doctors it has not been enough time before administering another dose, and how important that compassionate overdose management was, and how could we start to change the messaging so that people understand that the medication will not work faster by you putting more medication into their body, right? That it's designed this way. It takes time to onboard. So if you onboard too much too fast, you're just going to make them very sick. So what we were hearing is that people hold time poorly in an emergency, which makes sense. Our brain is going to shut down to fight or flight. We want someone to live. This is really scary and overwhelming, especially for a lay person. And then we've heard all these myths going on the internet where people are saying you have to use so much medication, and people think that's the reality when it's not. So we were thinking about what's the lowest barrier way to help people hold time, like maybe a stopwatch. Well, that can be hard to set up. Maybe there's not a battery. Not everybody has a phone. So we said a sand timer absolutely will hold the amount of minutes we want, and you don't need any setup to do it. You just have to flip it. And so when we do our compassionate overdose management trainings, we build in this component about waiting for the sand timer to run out before you reassess to see if someone has started to just spontaneously breathe on their own before administering the second dose. And a huge piece of this that's really critical is that you administer rescue breathing. And that's why we have the CPR shield too. I don't like to put my mouth on strangers. I get if you're coming across an overdose victim, you might have some comfort issues. So use the CPR shields. And even if you didn't, pull the shirt up over their mouth and cover their mouth and administer rescue breathing, because their brain and their organs are not receiving oxygen, which is really detrimental. So that's what you can do in that waiting space as you reassess to see if they've started to breathe again. In terms of people who may be in higher risk environments, whether it's themselves or their friends, but just everyone, I would say carry naloxone like it's first aid, right? That way you're prepared to respond to an emergency and save a life. This medication is safe, effective, and now sold over the counter at any pharmacy, and then available for free at many access points throughout our community. So it's really just part of being a good Samaritan by showing up and being ready to help others, knowing that there is this risk that we're contending with. And especially when we're in higher risk settings, like at a festival or at a party, let's have the tools necessary to make sure that our friends don't die.
Yeah, I think that's really, I don't think I'd seen the timer in there before. I think that's a really good, ingenious tool to put in there. That makes a lot of sense. So
100%. And then we have this little card right here that says, and this is from the kit itself, and it talks about 5 steps to respond to an opioid overdose, and it's super user friendly. It's really to the point. 5 easy steps, not a lot of language in there. It's pretty straight to the point. To go back to Dr. Herrera's point, which is when you are in a crisis, time feels eternal, and not having an immediate response, and I'm sure that could go ahead and be scary. But yeah, being able to go ahead and wait if there's no improvement after 2 to 3 minutes after the hourglass in this kit. And again, please reach out to Hope in the Valley CA on Instagram, or check out their website, to give them a call, and they will get you one of these kits pretty easily, honestly. But yeah, it's as Dr. Herrera said, being a good Samaritan. Anything else that I am missing when it comes down to this, Dr. Beare?
I mean, I think what's important for your layperson to know, and it's on those cards, is, you know, if you end up Narcaning someone, you need to call 911. Like the Narcan has a half-life, and it is shorter than the fentanyl half-life, or the saturation of fentanyl. It's not necessarily true. Fentanyl half-life is shorter, but fentanyl will stay in the system longer because of its unique properties. So if you Narcan someone, that's not the end right there. You need to make sure that that person is seen in the hospital as well, if at all possible, because it is not entirely uncommon for Narcan. You Narcan someone, they come to, but that massive amount of fentanyl is still in their system, and then when the Narcan starts to wear off, they can go right back into an overdose. So
I think too, beyond that, because I think calling 911 is really important. And then there's also some opportunities at the hospital to initiate buprenorphine following this overdose incident, if it wasn't just like contaminated drugs and someone struggling with an opioid use disorder. But there's additional steps, Ramon, that I think people can do to protect themselves from these contaminated drugs or counterfeit drugs, especially the population you were talking about, is using legal supplies that are available in our community, which are fentanyl test strips or xylazine test strips. And people are able to test what they're using in advance to know what it is, and then make some decisions about how can they keep themselves and other people safe, like that they have naloxone with them. Maybe they throw it away if that's an option. If not, other ways they could modify risk. But these are available tools where people can have more information about what's going into their body and how they can keep themselves safe. And they are legal in the state of California. They are approved by the Trump administration still as tools that can be used as life-saving overdose prevention methods. So not feeling like that there's no way to know what's going on. You do have tools available for free in our community that you can use to modify, what might be happening in a night where you thought you were going to go out and have fun and then someone ended up dying.
Yeah, absolutely.
And I think that's especially pertinent to those who are not intentionally using fentanyl, because a lot of my opioid use patients I'm trying to, that's what I'm buying. But you're absolutely right. Those people who are like, hey, I'm not trying to use any opioids right now, they should be testing pretty regularly whatever it is they're using.
Especially the pills, because most of the pills are counterfeit pills, and they're not Xanax, they're not Adderall, they're not Norcos, they're fentanyl.
Or they're both. And that's
both.
that's what happens, is that the fentanyl is being cut on the same surface that these other things are being cut by with local, small time dealers.
But on the pill press, they're just straight fentanyl.
Yeah, well, that's fun.
Yeah,
and it's so deadly.
And I'll definitely be working with Hope in the Valley to go ahead and get some of these naloxone kits, and I'll go ahead and have them available. I'm pretty easily accessible. So, but again, Hope in the Valley, very easy to find this organization on Instagram. Their website, their phone number, 661-412-4014. Again, it's easy to go ahead and reach out to me. And as we work towards the conclusion of this episode, I am curious to know if there are any other messages that you would want your patients to hear about seeking help, especially those that may be afraid because of the judgment or the discrimination that comes from being able to go ahead and obtain services that are very specific and essentially tabooed.
Yeah, so for me, I would want my patients to know that the environment we've created at my place of work, so I work for Clinica Sierra Vista, and our clinic over at Brundage 301 Brundage is a very welcoming, warm place. Our entire staff is aware, and they treat patients who are working through addiction. They treat them with dignity, with respect. There's no stigma. Our doctors, all of us in the clinic, sort of have the same passion and that same humanistic approach. I would think if I could shout to all the patients in the world or in the community who were struggling with substance use disorder, I would want them to know there are medications that can help with this, the same way there are medications that can help with other chronic illnesses. And while medications may not be the only part of treatment for any disease. It is certainly an integral part and a potentially life-saving part. And then the other thing is, there's this concept of like, no, I need to hit rock bottom before I seek treatment. No, like, no, not at all. We don't have that. Like, you wouldn't say that about your blood pressure. Like, I don't need to have a stroke before I get my blood pressure treated. No, like, let's treat it now. Even if you're like actively, using, and you're like, hey, I'm not really necessarily wanting to stop using. Like, I think getting an addiction specialist on board as like, hey, we can help you with being safe while you're using, meeting whatever it is your goals are. We can help you with that. So yeah, I think those are the messages I would want most out there, other than what I've already said.
I would add that for Dr. Beare's clinic, it's a clinic that treats people for primary care as well. So just coming to 301 Brundage doesn't signal to anyone in the world that you're struggling with addiction. Safety and privacy, confidentiality are big parts of empowering people to make health decisions, especially in the kind of environment that they could be living in where there's a lot of stigma, a lot of shame. So just knowing that by reaching out and asking for support and coming to that clinic, you're not being labeled as someone who uses drugs. You're just another patient, and you're going to be treated the same way. And I refer everyone we work with to Dr. Beare's clinic because I trust him. He's my doctor as well, and he's my family's doctor. I trust him to take care of people because I've watched him do it for years, and he treats them with dignity and respect. And what we hear, because we talk to his patients in qualitative interviews, is that they said they treat me like family. I don't know any other people like these people who are willing to do so much for us. Someone even said if these people stop coming out here, I would stage a protest. So the level of care, kindness, compassion is real. And I know that's not found everywhere in healthcare and treatment, but it is very real, when folks are seeking care from Dr. Beare. And there's other providers, trained by Dr. Beare and in our community, trained by others who have the same ethos, and that you will be received in spaces with dignity, respect, kindness, and compassion along a recovery journey. And it's going to take multiple attempts, and there's going to be people who are willing to walk that with you as you're ready. And please keep reaching out.
Yeah, and the reality is that I've had very limited interactions with Dr. Beare, but every single interaction has been extremely authentic, and I really appreciate that. So when Dr. Herera talks about the fact that there are so many providers that aren't culturally sensitive, or even remove the cultural component, just sensitive to the care that individuals come. So many people on my podcast, shameless plug, destigmatizedpodcast.com, so many of those individuals will go ahead and talk about how they don't receive that adequate level of care when they go see their medical provider. So honestly, to go ahead and hear Dr. Herera have that, those statements say, honestly, it just is a testament of who you are and what I have seen.
Well, so we hear this a lot, and it's really like, I love, hearing patients say like, hey, you make me feel comfortable. And I don't think that I'm doing exceptionally well at this. I don't think I have some exceptional ability to connect with my patients. I think that testament when people are like, hey, this is the first time I've been treated as human, that's not a testament to me. That's an indictment of the systems at large. I really don't feel like in some deeply empathetic human being, I feel like this is the same level of care that everyone has when someone is suffering. When you recognize someone is suffering, this is is human, where you're just like, no, like, what can I do to help you? What can I do to help meet those needs? And the fact that like patients come to us and say like, this is the first time I felt this way. It's nice to hear, but it's the reality is like, yeah, that's just because you've been treated less than human everywhere else you go, and that's horrible.
Yeah, and I think that your federally qualified health center that you're currently at has done a great job at being able to go ahead and reduce some of that taboo, some of that stigma. So major kudos to your federally qualified health center. Whether we're supposed to say names or not too sure, but I do have a lot of respect for your organization. And
no, Clinica Sierra Vista has given me, given our community a ton, and by letting us work in this space and giving us the ability to sort of rethink the standard of care for substance use disorders and rethink the approach. it has been phenomenal. So I'm not trying to plug anything in, but
No, for sure. We're just having an honest conversation. And I think when we talk about, this podcast for whoever is listening to this on a state or local level, we are in Bakersfield, California. So we have a lot of respect for the providers that are here because we're a very tight knit community when it comes down to it. And Clinica Sierra Vista has done a great job. And again, it's an organization that other organizations nationwide should probably reach out to their executive team and see what's going right for them, so they could go ahead and implement that and allow that conversation to go ahead and happen, to not feel other people, as you said, feel as if they've received less than care.
yeah, that really is like, it's a heartbreaking thing. I hear like literally every single day. So
I think that's part of what you do is so powerful, though, is that you are so engaged with the training of the next generation of providers. Dr. Beare invites residents and then empowers his fellows to engage in the practice of street medicine, which I think is really transformative in the way that service delivery, but also the philosophy of medicine is practiced. And, with the residents, also the training about how primary care physicians can treat, they're empowered to treat substance use disorders. Instead of saying, well, this is a whole different kind of doctor that should do this. No, this should be part of your repertoire. You should be comfortable doing this. This is how you administer care that is non-judgmental and compassionate, so that you can focus on the engagement and retention of this patient who's at such high risk. And I think your emphasis on that in the primary care training space is really important, because that's what's going to see long-term systems improvement in the healthcare providers, not just here, but as they go on their journey across the country.
yeah, no, I agree with that.
Anything else that you would like to add, Dr. Herrera, as we come to our end of our first of 24 episodes that we will be doing with Hope in the Valley and our series?
Addiction medicine works. Treat addiction, save lives.
Yeah.
Anything?
No, I think that's it. That nails it, man.
All right, perfect. So again, this is our first episode with Hope in the Valley. This is our Hope in the Valley series, and this is our first episode, which is called "What Works in Addiction Medicine" with Dr. Matthew Beare, Dr. Beare, Dr. Herrera, my co-host. Thank you so much for your time. Really appreciate it.
Thank you.
Thank you.
Great conversation.